Hi, Dr. Snyder.
Most excellent greetings. Thank
I'm
you.
glad you could join us today.
Yeah, I'm going to get my window here with all the awesome white light coming in. Kind of fixes my interoceptors when I do that.
I like that hand behind you. I have a few of those in my office too.
This one moves from time to time, so I have to keep an eye on it. So.
Hi, Dr. Dagenhart.
Hi.
Hello, Sarah. Hello.
Hello.
How are you?
Thanks. I'm fine. And you?
I am good. How should I refer to you?
Sorry? Refer?
Yeah, your name.
Oh, yeah. I'm Thomas Hoegy. I'm from France. And I'm sorry for my English. Not very well. It's the first time I do this.
Well, we're glad that you. Yeah, it's coming over great. And you sure picked a complicated paper to take on. So good luck. We're looking forward to your presentation.
Thank you. So that's an interesting paper too.
Indeed.
Yeah. You asked me when we go, when we can go.
Dr. Hoegy, I will introduce you and then we can get started.
Okay.
Okay, all right, let's go ahead and get started. It's the top of the hour. So welcome everyone. My name is Sarah Minirad and I'm the PBRN coordinator with DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let us take a moment for the housekeeping rules of the webinar. Please add your name and location into the chat so all participants can see who else is attending the webinar. If you've registered for CME credit, you must add your name in the chat to verify your attendance in order to receive CME credit. Additionally, you will need to complete the physician attestation form, which was emailed to you this morning, and the evaluation survey, which will be sent to you this afternoon. The Let's Talk About OMM Research Planning Committee has no conflicts of interest to disclose. If you have any technical issues during the webinar, please send a message to me, Jane Johnson, or G. Franklin. If you have any questions or comments during the presentation, please feel free to type them into the chat. Please feel free to address each other's questions and comments there as well. After the presentation, we will have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. We ask that you briefly introduce yourself. Please feel free to turn on your camera if you would like. When contributing to the discussion, please limit the microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. We will provide you with notifications using flashcards to assist you to keep track of time. Please keep in mind that this webinar is being recorded and will be placed on the DO-Touch.NET website, where you will have the opportunity to continue the discussion. Watch for an email from DO-Touch.NET announcing when the recording and the discussion forum are available. Now, please help us welcome Dr. Thomas Hoegy, who will be speaking about the journal article Osteopathy and Mental Health, an Embodied, Predictive, and Interoceptive Framework. After his registration in 2011, Dr. Thomas Hoegy started to work with Ronald Ellis in France. He has taken part in many collaborations and postgraduate formations and also received a university degree in osteopathy and posturology from CISO Lyon. In 2016, he started to work with the Public Health House near Lyon. In his vision, mental health, cranial osteopathy, and whole person-centered care are reliable. Please help us welcome Dr. Thomas Hoegy.
Hi, everybody. I share my screen.
Yes.
You see this? Okay.
Yes.
So we are speaking to osteopathy and mental health, and embodied, predictive, and interoceptive framework. You stop me if I don't speak very well, and I have to explain. Thank you.
Thomas, if you could put your presentation in slideshow mode.
Okay.
Down in the bottom right, just to the left of the slider.
No, that's not. Okay.
There, thank you.
It's okay.
It's good, thank you.
You're welcome. Okay, donc I'm an osteopath in France, and I'm a member of a non-pharmacological interventional society for research in many ways. Osteopathy and manual treatment, also musicotherapy, or any many non-pharmacological interventional. I'm a teacher also in Osteo in Lyon, and so the cognition embodied. We are speaking about the comportamental inhibition, so the soul, the visceral sense, and the feeling. So the adequation of sensibility and action. The diagnose and the treatment. So also for the patient, an action open by physical ecology guidance for diminution of anxiety. We have to make this, to try to make this in the depression, the fear avoidance, and the anger. I think so. The retroaction positive for decision with cardiac coherence is important part of the treatment, and particularly useful in somatoform trouble of conversion. So we think our role is in finest perception, insight for open Umwelt, in grace of nociception, neuromodulation. That's Mr. Bertos tell this also. Without a lot of anticipation for neurofeedback, with ingress of neuron hubs and black matter. We stimulate the default mode network for self-healing, and the manual treatment help or could help patients to make contextual inference by movement in daily life near the psychological intervention. We have to address the patient, contemplate him to incarnate him with his cognition and the manual treatment we make. So with proposition to adjust saturation of multisensoriality for emphasis, double conscious by conscious of the world, grace of proprioception. So we can speak about the multisensoriality of the touch of the therapist and the osteopath. And more than a sixth sense, the proprioceptive sensibility could be a first sense and indispensable to emergence of self-conscious, in as much to be able to action. That's the Dr. Roll tell us about proprioception and the proprioception, the midline between interoceptive and exteroceptive. So introduction of the article tell about the psychosocial and socio-professional risk of chronic stress and addictive disorder. So the burn-in, the burnout, or the overuse syndrome, and the burnout, bore-out, or depression. So we can compare it, the consequence in the patient body to hyperventilation, buccal respiration, and blood acidification and lack of recuperation. So it's neither purely somatic nor purely mental. That's Burton tell us about functional somatic disorder, and we can tell about Michalak and Zarif about body, mind, spirit principle and synaptic plasticity of the intervention of the spirit and the mind through the body of the person. Osteopathic treatment attempt to readapt prefrontal cortex and ideomotor orbitofrontal by way of the lemniscal pathway, right in particular. We developed this after. The visceral, cranial, and myofascial approach with static touch and emotional verbalization are important in this type of treatment, but in the manual intervention and the globalization of the intervention. So change of paradigm with sensory motor card modification, including throat, grace of extero, intero, and proprioception. I said this before. Alain Berthoz tell us it's little changing in morphology can be a lot for the movement. So the amplification of the cause and or the manual intervention can be a lot for treating movement. And we ask in find the morphology of the body. So osteopathy is like enriched environment for neuron mirror. We can tell this, and the left precentral inhibition, reinforcement of thalamoparietal and external striatum body are like a neuromediation with the palpation and the touch. Ecology and affordance of cognition and the physical economy and ergonomy are two parts of the treatment. So we address manual touch for physical economy and ergonomy. So also the affordance of condition and the ecology of this for patient. So does not have model of the world. It is the model. Gallagher tell this in this year, and we that's it's the patient is the model, and we have not imposed to treat him. We have to reinforce and readapt the connection through this thought and his body feeling. So in posturology, we speak about reality subtraction for abstraction, and we have to make inhibition of osteopath treatment and the osteopath body for intervention in the I continue. But create the state of the world predict with best generative model. Paulus and Van Tel tell us the predictive coding and the Bayesian hypothesis. Life is open, and we have to open also the patient. Free energy can store chaos and resistance, and we have to diminish the entropy and the disorganization or transformation. It's the possible inadequacy in perception, action, and result. So in chemistry, the semi-permeable membrane, we are like this for patient, I think. And the hypothesis Bayesian, so the cohesion of the belief and the sensory input, perception in one side and expectation in other side, can predict error a little bit, and to reduce we have to reduce this by treatment. So adequation top down and bottom up, but also backward and forward are important. Feed forward inhibition for predictive correction and make patient be amazed from present. The depression and anxiety show depression and anxiety show high expectation of situation is instead of hyper precise prior and context rigidity. So intervention target interoception and behavior. We reinforce, we tell this right ventroposterolateral thalamocortical loop in interoceptive inference augmentation. So the left inhibition of photopolar and cingulate for diminished error of prediction. And the self point of view is also inhibited. In this way, the changing the world through action to confirm one's own belief, and it's like active and inactive process. Belief supplement sensory information and symptom. That's okay. I continue. The interoception, and we ask the probability in interoceptive inference and the visceral sensory information, also the descending interoceptive predicting via the insula, and the homeostasis via autonomic reflexes. One dominates for diminution of predictive error, and generative or sensory information are two parts of the the problematic, and sensory motor system are autonomic also. Via agranular and supragranular prediction error and mood state for allostasis, that's the conscious of emotional experience for treating functional disorder, medically unexplained and symptom and chronic pain. We're thinking in osteopathy, we have to optimize, restore, or maintain patient structure, function, and well-being. That's we have to bind sensation and affect to readapt dysfunctional defect for adjust default mode network and rehabilitate without default. If it's possible, hands-on address to support and sustain tissue, and we have also to bind skeletic and orthodontic classes to adjust bio and morphotype with behavior. So René Char is not an osteopath, but tell impose your chance, stay happy, and take risk. The patient have to do this in his life, and we have to do this for him also. We allow yourself to sing the hymn with osteopathy. We allow yourself to sing the immeasurable, the unspeakable, and the thought of existence between conscious and unconscious. Can we reaffirm capacity of composition with reality and genomic expression by minds of connectum of the patient? Maybe. That's the objective. We can tell hands-off modulation and the patient education, the psychoeducation, the lifestyle of him, and the gestion of mental state. That's the objective on this for after I present you sorry. That's meta model of touch and neuromechanic via fascia and allostatic palpation. So we address neurophysiologic to neuropsychologic for patient. We address neurophysiologic and he address neuropsychologic. So homeostasis without stimulation. And the WHO organization tell about structure, function, and dynamic and self-regulate. That's so the principle are we are thinking about find health instead of disease, treat cause rather than symptom, person-centered, holistic treatment, and manage strategy, the patient knowledge of and the patient and his perception of health. Tell Bolan. So the guideline to the Mainlands and the manual paradox explanation to ask and tell with the patient for changing paradigm, sensitization, underlying inflammation diminution, of course, and light touch to deep touch for augmentation of interoceptive accuracy. So that's a little bit bigger than the screen. Okay, like this, you can see the type stimulation and the receptor. In the first case, and the fast movement, we address position, articulation, muscular stretching, diagogy, and muscular spindle. So that's the way, the pathway, and after the fiber and wave via the alpha R fiber, and the nociceptive, that's motor and sensitive. And the type of touch and the self activity are complementary personal stimulation. We can class the dynamic therapeutic input and the articular mobilization, the HVB technique, and Mitchell and muscular technique. So for the mental state and the mood disorder of depression, for decouple interoceptive input from interoceptive prediction for non-intrusive via the cortex agranular visceroparietal. That's the predictive coding model. We are also predictive coding more than I think, and that's a proposition in this diapo. In motor and sensorial fiber A, gamma, and delta. So the mechanoreceptor via Pacini, Meissner, Ruffini, and Merkel are termination encapsulated and ask the cutaneous complex stimulation for sense of position, vibration, and degree of pressure. So it's the nociplastic and the pressure superficial to deepest via light touch to deep touch, and ask the functional techniques, the myofascial release, the lymphatic, vascular, and vibration like the patient we can reinforce personal activity like Tai Chi, Qigong, yoga, Pilates, and gyrotonic. And the mental state and mood disorder are particularly chronic pain, psychosis, addiction, and neurotic. That's not an exhaustive presentation, of course, and the mental state and the mood are fear and anger. That's the Bayesian model addressed this type of stimulation and pathway. The motor receptor address the muscular tasting and technique, personal inference with physical exercise. So it's a good that's good technique for the autistic and mental disorder. Sensorial light touch are thermosensible, idler, low threshold of activation, and the fiber A delta 3 are free termination via the lemniscal inhibition pathway for address the nociplastic also. And that's for myofascial diagnosis, the friction stimulation, the component for visualization and emotional state. So the patient can address him so via the sophrology and the respiration exercise. That's a good idea in post-traumatic disorder via the predictive coding to reinforce the connection between the body and the mind of the patient. So that's the article tell us via C fiber a lot of intervention of our practice and manual treatment via the hot thermic and non-painful late acute burn-like receptor, sorry. Via the neuropathic, motor and sensitive cutaneous, particularly visceral and central axon also. That's the extralemniscal way. The soothing overall and the gentle, slow moving touch, low force or surprising are a good intervention in this problem. And the meditation, heart rate variability, cognition, behavior therapy, pharmacology also, and neurostimulation with affective information, auditory attention, and song of voicing we attach to this. We can also adjust the patient visualization and dietetics and reducing worrying belief or illusory sensation. It's the mood of anxiety and depression via granular relaxation. So we address also in schizophrenia maybe, and atypic augmentation interoceptive ability. So the food regulation failed to update weight and compulsion and panic disorder. The chronic pain is and the functional disorder are a lot of connection in sea fever, and we address also the waking, the sleeping state via this way, and via insula, enterocingulate cortex, sensory motor, occipital cortex, temporal and prefrontal. So we reinforce the right and inhibit the left. That's more complicated, of course, but the thalamocortical loop we ask before we reinforce in the right way. So interoceptive, that's the interoceptive coding. So conclusion and expectation, of course, we address the body of the patient, but we ask, we have seen a lot of connection with psychological disorder, mood also, and we can combine the touch and the music in the treatment. We think also another intervention. Psychosomatic fear of pain in pediatric with abdominal pain and chronic are addressed in salutogenic challenge. So collaborative approach in osteopathy for musculoskeletal disorder treatment. That's the next article. I can't find the time for read it, but benefit in mental ease. We have seen. The WHO tell us the factual based on art role in health, amelioration, and well-being, and we have to remember this in neurofunctional and neurocognitive disorder, so neurodegenerative also, and the mindfulness informed top-down and bottom-up touch-based via interoceptive cortex, like Dr. Steele or Dr. Sutherland tell us about the fulcrum, the still point, and the automatic shift from fulcrum for stillness. So it's the contemplation of the patient body by himself, and for incarn him. audio cortex link emotional mother affect and father security just before and after birth. We reconnective legacy inherited maybe with therapists, and that's the enriched environment. We tell about this in the debut, and the multisensoriality we approach for the patient. So that's a psychophonist, Marie-Louise Hoegy. The falling body is driven by a rain of soul for a state of mood and mental disorder, but also via interoceptive framework, embodiment, connective and interoceptive framework. That's the objective, and embodied spirit for contemplation, tell Pincus and McLaren. So that's the comorbid psychological factor combining with psychotherapy in many ways. Of course, but we can see it's more complicated and more large than on, off, or in out system. We have complementation and complementarity. For the approach for mental illness, but in the treatment, the manual treatment in general, much precision too pure or too little likelihood. Yeah, that's the personal noxious immunity and reactive and proactive inhibition. That's the neurotic structure. Tell him no stress, and reactive and proactive inhibition. That's okay, but we have to liberate this inhibition. But if it's just liberation of inhibition, that's a resurgence of repressed psychotic structure, mental structure, and the psychosomatic liberation of central sensitization inhibition are more likely the osteopathic and functional disorder we treat, we think. And other psychological structure and neurodegenerative disease, we tell not in this presentation, of course. Of letting go, oversight and hope are permitted by osteopath between music, song of the voice of the therapist, and therapeutic dance, harmonic techniques, in theater framework. Why can't we advise patient to be conductor of his phenotype with aesthetic empathy? That's a French organization to open to work for mental disorder and invitation to beauty. All I know is that I don't know, so it's the question. But we have a framework with this article, and cause and solution in himself. That's also the salutogenic model. And osteopathy favorize multisensoriality, like enriched environment via interoception and modified conscious state of mind for stimulate cognitive reserve, like a golden buzzer of resilience. That's more and more complicated, but it's okay for this with the presentation of this article, and reduce the prediction error and reinforce sensory information with a modification of belief for prediction in the future of the patient. And that's the reference I use in for this presentation.
Thank you so much, Dr. Hoegy, for that presentation. Dr. Degenhart, did you have any comments or clarifications you wanted to make?
Well, first of all, thank you so much, Thomas, for the presentation. This was a very groundbreaking article that really puts an osteopathic model in a very modern context. And there's a lot of new terms and concepts within it that I think we all are going to have to spend some time to better understand. I do have a question with slide, I think it was slide number 14, just to make sure that I understood what was written there.
Mm-hmm.
It was no, not 14. It was the first one of your table.
Sorry. Okay.
Yeah, perfect. Tape 14 right there, 2 down. Yeah.
This one?
No, the one above it. Okay, so when I'm looking at row 1, the first top row, and I want to just make sure in the second box, it says, so A alpha fibers. Those are motor fibers. I don't know of any nociceptive component to those. So when you have nociceptives, what does that mean?
Yeah, it's the receptor of the movement, of course, and if it's too long, we can translate or transcribe in the other fiber for nociception. That's not the model exclusive of nociceptive, of course. That's the address of the elongation.
Okay, thank you.
You're welcome.
Are there any other questions?
Yeah.
Dr. Snyder, I see your question. We do have a question in the chat that I wanted to get to really quickly, and then I'll get to you. So Dr. Hoegy, we just have a question in the chat that says, could you address the audio cortex information more? Dr. Fryman used to use music and used a filtered music program from a French ENT, Alfred Tomatis, for some of her patients.
So can we repeat? I think I understand, but can you repeat?
Yeah, so it says, could you address the audio cortex information more? Dr. Fryman used to use music and used a filtered music program from a French ENT, Alfred Tomatis, for some of her patients.
Yeah, I'm not. I've not explained in this. But I think there is an important link between emotional and the voice of the therapist in the first action of treatment, but with with a sound and the band of a neutral song. I think we can reinforce the sensoriality of the manual intervention. But the audio cortex is not a word, proper word. It's all the cortex, of course. That's okay.
Yeah, thank you, Dr. Hoegy. Dr. Snyder, did you want to ask your question live, or do you want me to just read it from the chat?
I think if you can see it or you just read it would be fine. Okay. If not, I can add some extra to the question.
Okay, Dr. Hoegy, so Dr. Snyder asks, for the tables on slides 14 and 15, how discrete or how much spillover do you believe is present between the categorizations and type of manual touch and the receptors, fibers, and pathways?
Sorry?
So how discrete from your tables, how discrete or how much spillover do you believe is present between the categorizations and type of manual touch and the receptors, fibers, and pathways?
Yeah, I'm. That's a proposition, and for the connection of the pathway and the intervention. That's not simple like this, of course. And we address this the extralemnic scale way. Sorry. For cutaneous touch and the gentle and light touch in the first intervention, the debut of the intervention with low force and sourcing overall.
Great, thank you, Dr. Hoegy. Yeah.
That's the discussion of the article, and I try to enlarge with another pathway, but it's combination. Sorry.
Thank you on that. There's always the challenge between what people think they're doing and what they are actually doing.
Yeah. That's the question. We have to adjust our touch with the react of the patient and the reaction of the patient, and also for surprise him, and we tell we have to in the diapositive like also okay changing morphology, but finest perception of the therapist of in patient for open easy insight. And sorry, we have to this in the patient amazed from his present for translate the manual touch and the intervention with voicing or conseil for top down in his life regulation.
Yeah.
Thank you, Dr. Hoegy.
Yeah, thank you for the answer. And the part where you're able to help train someone to be shifted or learn to shift in response to the patient's response. I mean, that's a challenging issue.
Okay, I think we have another question. So can you clarify a time in which I should be hands off with patients with psychic issues, is what it says.
Okay.
Dr. Hoegy?
Sorry?
Did you hear my question?
Oh, no.
Oh, okay, I'm sorry. Okay, so the question is, can you clarify a time when I should be hands off with patients with psychic issues?
Okay, hands off with a psychotic issue. That's it.
Yes,
Yeah,
that was all they said. Yeah.
That's the challenge, of course, because we have to make a cohesion with him, but it's difficult in many ways in a psychotic patient, and that's maybe in the first time we can't do a touch with autistic. Of course, and I think the music and the repetition of the stimulation with the same address and the same issue in the treatment can reinforce the connection with the therapist, and in second time in second time we can change the tap down maybe, but in with adjust in life of the patient and the rehabilitation of his another not therapist but professional in his life. He helped him. It's okay.
Yeah, Dr. Degenhart, did you want to add something to that?
No, I was just going to offer people online, being that this is a theoretical paper bringing together a lot of different current models and ideas. If for those who want to, if they want to just summarize what kind of their key concept or insight that they gleaned from this, I think that might be interesting for us to hear. So if anybody's willing to offer something that they have heard that was particularly interesting, just one, that would be great.
Thank you, Dr. Degenhart. While people are thinking about that, Dr. Hoegy, we have another question. So the question is, what are the implications for the nature of tissue memory and its release?
The nature of memory of tissue and?
So the implications for the nature of tissue memory and its release.
And its release, okay. That I think that the treatment of this way and the tissue release in passive technique and readapt in active personal stimulation for self-activity change, maybe for the connection of his environment passion in his daily life. That's okay or not?
Yes, no, that was great. Thank you, Dr. Hoegy.
Thank you.
So I believe this is in response to you, Dr. Degenhart. Dr. Robbins says her takeaway was tissue substrates and receptors are significant in hands-on and hands-off approaches. Does anybody else have any? Yeah, go ahead, Dr. Degenhart.
Yeah, for me, the fact of, one, that our hands-on approach can help deal with some errors within their central nervous system in regards to misinterpreting perhaps their interoceptive signals, that actually help them get better connected to their body. I think this is the first time I've heard a mechanism that could potentially explain that observation that a lot of times we have. So, and I think the other part that I had was the fact that when we touch any part of the body, that their reaction to that touch can be a result of a lot of different factors, from their memories, their previous experiences, and so forth. So knowing that environment and the person themselves and their beliefs are all very much active in the osteopathic approach to them. I think that was something that this article
yes,
really
of course,
said.
Of course, yeah. I think also.
Okay, does anybody else have any other questions or comments before we sign off? Okay, Dr. Hoegy, thank you so much for this wonderful presentation. We really appreciate having you here today.
Thank you. Me too.
Yeah. Dr. Degenhart, do you have any additional final thoughts, comments, ICMT, anything you want to say?
Just a couple of announcements. So next week, DO-Touch.NET has its annual meeting. It will occur on Wednesday. It is going to be in person in Orlando, and there are online opportunities for people to participate. So if you have any specific questions about that, you can contact Sarah for more information. We have our next program in April. That will be a update from DO-Touch.NET. And then in May, we have a special program that DO-Touch.NET will be sponsoring within the International Consortium on Manual Therapy's inaugural conference. And that is a revolutionary conference model. This conference is actually going to occur throughout the month of May. There is a main program that's going to occur on 4 specific days, on a Friday and Saturday, May 6th and 7th, and May 20th and 21st. And then there are a variety of extra programs, special interest programs that are going to be going on during the month. And you have access to be able to be there live or to watch them at your convenience, and to rewatch them at your convenience to get the most out of the information being presented. So please, you can go to icmtconference.org to get more information about it. Certainly, if you have any questions about that, you can get a hold of us at the Institute, and we'll be happy to get you more information.
Thank you, Dr. Degenhart. I just want to point out real quick, we had a question about the Advanced Osteopathy Skills course. So we have one coming up in August, but those slots are pretty much full. And then we have openings in 2023 for some courses happening then too. So if your group is interested in doing an ASO, just email me at do-touchnet@atsu.edu and we can start working on that together. All right. Thank you all so much for joining us. We'll see you back next week or in April.
Thank you.